Okay, we're recording. Nobody swear, please. Hi, everybody. Thank you very much for joining. Good afternoon. We've got usual kind of format at the moment. We've got speaker to share some great work. So Anne's joined us today, and then we'll just open the floor if anybody's got any questions or anybody to Anne, and then afterwards, anybody's got any thoughts or particular sticky issues they want to share or talk to each other about or get the wisdom of the crowd, then we'll have a platform and a bit of a time where we can spend doing that if you think that's helpful. So have some thoughts if there's anything you want to kind of ask the group. I see there's been a bit of chat on the WhatsApp group. That's always really helpful. So use this network to maybe ask a few questions if you think you've got a particular tricky problem you're trying to overcome, or just to have a bit of a sense check if you're on the right track from the work that you're doing. So I'm going to ask Deb. Deb reached out to me a few months, well, I think it's before Christmas now, and said to me, I found this amazing work that Anne's been doing, and I think you'd be really interested. So I thought, yeah, well, I'm obviously always interested, but so I'm going to let Deb do the intro, and then Anne, you just take it off from there, and you can the floor is yours after that. So I'm going to hand over to Deb.
Thanks very much, Nick, and welcome, Anne, to the network. So I have had quite a few conversations with Anne recently and over previous months and years. And Anne is a real expert among many things with supporting people and learning through the leader process, and really focused on improving outcomes for people with learning disability and autism. And we had a conversation about something completely different, but there was some real overlap and synergy with some of the work that's happening around reconditioning and supporting people to keep active and moving and well. So I'm going to hand over to Anne because her presentation explains the whole context and all about this piece of work. And I hope you find it really interesting. Over to you, Anne.
Thanks so much, Deb and Nick, for inviting me. I'm really, I don't feel like I'm an expert, but I'm very much a general nurse with a particular interest amongst people with a learning disability. So I'll do the presentation, and if I've spent too much time talking about the context of leader and not enough about the work around aspiration pneumonia, I can always sort of rectify that and send you some more slides. So I'll start. So this work is really grounded in the leader programme. So I joined the Cambridgeshire Peterborough ICS as their local area contact for the Learning Disability Mortality Review programme. And it's about learning from lives and deaths of people with a learning disability. And can I move my slide on? So there's links there to our annual report and the last national annual report. The annual report nationally that we were expecting in November hasn't actually come out yet, but it shouldn't be long. So the LEADER programme is a service improvement programme, and it's really aimed at improving outcomes for people with a learning disability, reducing health inequalities and preventing premature mortality or avoidable mortality. And you'll see in the subsequent slides what I'm particularly asking this forum to sort of take on board and sort of think about in your work areas. So we do the reviews looking at GP notes and any health and social care records, and talking to people who have known the person who's died. So it may be a family member, it may be professional people who have cared for that person. But it's not an investigation, and they're not, to that end, the reviews are subjective. So just to put that in context, and because notifications are expected but not mandated, we can't be sure that this is a complete data set. And where you have backlogs of reviews over a number of years, you don't get the entire data set for a particular year group in a leader report. So it's just to sort of qualify some of the data. We can't be absolutely sure we're talking about all the people with a learning disability. deaths of people with autism have been reported to the LEADER programme since 2022. So the number of autism-only deaths that have been reviewed are quite low in number. So this presentation is focusing on learning disability. And I've just popped the definition in there of learning disability because people that aren't caring for people with a learning disability regularly may not realise the difference. Often people use the term learning difficulty, but that refers much more to things like dyslexia and dyscalculia. But a learning disability involves limitations in intellectual functioning, the ability to understand new information or complex information, and that's why it makes it very difficult. Well, a different level of difficulty but it's different to navigate life and navigate things that people in the general population just take for granted. So the first point to really look at is that people with a learning disability die over 25 years sooner than people without a learning disability. So we're looking at people dying in their 60s that's the median age at death. But generally, there's people with more profound learning disabilities are dying younger still. People of Black and Asian ethnicities are dying younger still. And it's really important that people caring for somebody with a learning disability on their ward knows that that person is at risk of dying at a much younger age. Where we have older adult wards in mental health, it's generally over the age of 65, and in acute medicine it's over the age of 75. For people with a learning disability, very often they don't even reach those ages. So all the work that goes into reconditioning and prevention of deconditioning in the older adult wards isn't accessible to people with a learning disability on more general ward environments. And it's considering that everything that we do for somebody in those older age groups, everything around frailty, advanced life care, advanced care planning, we need to consider at a much younger age for people with a learning disability. Because while we want to prevent any avoidable deaths, we know that a lot of these people are going to die at a much younger age. So really focusing the mind that if you have a person with a learning disability on your ward, they are at risk of dying. We're seeing an increase, infections and sepsis are leading causes of death. So chest infections particularly, and there's a lot of work we know has gone into prevention of catheter associated UTIs, and there's been a lot of work in care homes about reducing UTIs, but chest infections is a really significant cause of death amongst people with a learning disability. And then pneumonia leading to sepsis, it's the most common cause of sepsis. We are seeing an increase in deaths from cancers, and often there's a very late diagnosis of that, but I'm not going to talk about that today because I want to focus on the work around aspiration pneumonia particularly. And we know from the literature, we know from reports like death by indifference, which led to the confidential inquiry about patient outcome and death, and then led on to the LEADER programme, that people with a learning disability have a poor experience of general hospital care. So that is what started the LEADER programme off. And it's just, we keep finding examples where people with a learning disability are having poor experience of general hospital care. So it's really important that we look at this, but also that we collect data to demonstrate any areas of improvement. So staff in general hospitals feeling ill-equipped to deal with the needs, to meet the needs of people with a learning disability was found. I mean, that's just one study. It was in Northern Ireland, but we do have learning disability liaison teams, but we also know that there's a real challenge amongst the learning disability nursing workforce and the lack of places of people joining learning disability branch of nursing. So we really need to join together and have this joint workforce. real multidisciplinary approach. So in terms of prevention and early intervention to prevent premature death, what I'm asking of all the activities that you do with reconditioning and prevention of deconditioning to be available to every person with a learning disability, and that all these initiatives that happen in hospital, that we can support the development of processes to identify people with a learning disability who are at risk of aspiration pneumonia, which is our top cause of death, plus training and education on how these risks can be reduced and any cases identified early. And with data, any data that you collect, please collect and publish any data on the people with a learning disability that use your services, because we have a real issue with being able to cut data in all services, and I'm not talking just acute hospitals, talking in the community, in social care, to really show the impact of and the outcomes for people with a learning disability using the different services. And every person with a learning disability over the age of 14 is entitled to an annual health check. And from that annual health check, there should be a health action plan. And we really need to join the dots of these. People should have health passports that follow them through whatever care setting they're in. But it's really important that we link to this annual health check so that it follows them throughout the whole year, that we actually use it and make it meaningful, and we can contribute whatever care setting we're in. So this is linking back to the Cambridge and Peterborough annual report. So the data that I'm talking about for hospital admissions today is based on the 39 completed leader reviews, and those deaths occurred over a 5-year period. So the longest ago was in 2018, but over half of them were in the previous financial year. But the causes of death were very comparable also to the leader notifications received for the same period of last year's notification, sorry. So it's just to say that these causes of death, and anyone can notify a death to leader. So it's in the NHS standard contract that any NHS care provider will report deaths to leader, but if nobody's going to be prosecuted if it's forgotten. So that link there is the link to the leader platform. The details are checked and duplications are removed, so it's no problem if more than one person inform, and you don't have to have all the information to report it. But one thing that still comes up is that a learning disability is not a cause of death. There's Down syndrome doesn't lead to death. This person's death was with Alzheimer's disease. Down syndrome can appear in another significant condition contributing to the death in section 2, but it shouldn't be listed as one of the immediate causes of death or as a reason not to resuscitate. So the demographics for our leader notifications, the median age at death for our service users is 61 years, which is slightly lower than the national figure. And there's a difference by gender. If you look at the graph on the top, you'll see that the age of men at death, there's many more deaths amongst men in that sort of middle-aged bracket, the 50 to 64. We have a higher proportion of men with a learning disability that have died in Cambridge and Peterborough, but this is similar to the proportion of men on our learning disability registers. And the median age at death for people in our Peterborough postcodes was over a decade younger than people in our Cambridgeshire postcodes. So while there are areas of deprivation in Cambridge City, generally Peterborough is a much more deprived area. And if you get to know your area that you cover, when I did my training and I did a lot of my wards, I was at Barts and went to Homerton in Hackney. doing my community placement, it was like a complete eye-opener to see the deprivation. And, you know, for example, there's the Peterborough postcodes PE1 to PE7. The actual median age at death there for men was 53 years, so that's younger than I am now. And one man who died in that postcode, he was in the care of his mother, had been in the care of both parents, and then the father died, and so she couldn't any longer take him upstairs to bed, so they were both sleeping in the lounge, so 2 beds in the lounge. There was no personal space, and that's what deprivation looks like in some of these areas. So the person with a learning disability from a deprived area on your ward is at risk of dying at an even younger age still. And with ethnicity, we know that people with Black and Asian ethnicity die at a much younger age compared to the white population, but that wasn't borne out in the figures that I had in this year's annual report. And because the data set is very, very small, we need to analyse data over a longer period of time. But nationally, that certainly is the picture. So place at death, 2/3 of people thereabouts are dying in acute hospitals, which is more than the proportion of people in the general population that die in hospital. We only saw 2 people die in a hospice, and there's very little evidence of advanced care planning. And sometimes you see that frailty is mentioned on the death certificate, but it's never been mentioned in previous assessments. And so we know that people with a learning disability develop frailty at a younger age, but it doesn't seem to be recognised or addressed at a younger age. So it's just, again, if you are doing activities to prevent frailty, to manage the onset of frailty, thinking that people with a learning disability need to be considered at a much younger age. We know that the clinical frailty score wasn't validated amongst people under the age of 65, I think it is. And so there is work, there's some work in Hertfordshire going on to look at a frailty score for people at a younger age. Aspiration pneumonia has been the most common cause of death for the last few years in our area, and it is like one of the major causes of death nationally. So it's the most common cause recorded in section 1, and sometimes the underlying cause. So it's the cause of death that leads to the death. And then the underlying causes are sometimes listed as influenza, COVID, dysphagia, esophageal reflux, and dementia. And the question really for everybody on the call is, are we doing everything possible to prevent the person with a learning disability in a hospital setting or whatever setting, preventing them aspirating or developing a chest infection? So we are focusing on this in Cambridgeshire and Peterborough to really develop systems and processes to focus on bringing so many of the pockets of good work that happen to prevent aspiration pneumonia and hopefully drive down lengths of stay, avoidable mortality, and so on. So aspiration pneumonia, I'm sure most people know, but I put the slide in just to say it's a type of pneumonia that's caused by bacteria entering the lungs, and it may be accidentally from food or fluid, it may be from saliva, the person's own gastric juices. But these risk factors that lead into it, the swallowing difficulties, poor oral hygiene, where the bacterial load in somebody's mouth increases. When people change care settings, things like oral hygiene may be one of the things that isn't followed through. They aren't having particularly good oral hygiene, or if they've got mealtime support needs, then maybe if they're already suffering with a chest infection, they may not have the postural support, they may not have the correct seating, they may not be able to bring their wheelchair into hospital. All these things are examples of where we've found people with a learning disability disadvantaged when they've been admitted to acute settings. So these were just 3 of the cases where we had people dying of aspiration pneumonia, and you can see the age at death is very young. So a 30-year-old man, this was the man who slept in the lounge with his mother, profound learning disability, suffered fecal impaction and then had some overflow, vomited fecal fluid and aspirated that and that occurred in hospital. A 24-year-old woman with a severe learning disability, and she had a neurodegenerative condition. So she was considered frail at 24, but the first mention of her frailty was in the ITU admission shortly before her death, and it was given as a reason for not intubating. And a 55-year-old man with epilepsy, multiple admissions with constipation and aspiration. And so epilepsy occurs in about a third of people with a learning disability. Constipation, often starting in childhood, is a common issue. And these are all things that need to be managed when people move care settings and can be made worse by another reason for admission. So, for example, if they were being admitted because they had a chest infection, they're much more prone to constipation, or maybe the seizure threshold may change. PEG feeds, often people with a learning disability having their PEG feeds, but maybe not being positioned correctly when they're having that feed while they're in a different care setting. So these are just some of the factors associated with aspiration pneumonia from our data. So none of these people had a mild learning disability. There were people with moderate to severe learning disabilities. Virtually all of them required a special diet of some description, whether that was puree or a PEG feed. So they needed some support to get their nutritional needs met. And nearly everybody had a degree of assistance needed with their mobility. So this is why, you know, the parallels with the reconditioning work when I was talking to Deb. And then hospital length of stay. So it's quite a small data set. It's over a number of years. So there are COVID times within this data set. But it was enough that it made us sit up and think, hang on a sec, we've got 24 people that stayed in hospital for 551 days. 1/3 of them had lengths of stay over 3 weeks. So, and then when you delve a bit deeper, some people were medically fit for discharge, but then unable to be discharged and then developed their final illness. So they're the ones that are real red flag to need the reconditioning work. But very little evidence of advanced care planning. So these deaths didn't appear to be expected in any way. And this is something that, you know, it'd be really interesting if we could cut all hospital data for people with a learning disability, but where we have issues with coding, because all the different like learning disability itself, although you can have people on the learning disability register at a GP practice, that data doesn't necessarily get matched with admission data with acute trusts. I've just noticed the time. I'm going to stop talking so quick. So this is what we do with service improvement. So we're engaging stakeholders. Some of it's about policy and commissioning, but a lot of the work is around teaching on a local basis, making sure people learn and understand that people with a learning disability are at risk of an early death and what their causes of death are. So this is a very simple, this isn't the proper driver diagram from the whole work. It was just something that to start the process off. So we're doing some continuous quality improvement work with one of our acute trusts at the moment, hoping to roll it out to both, to really look at prevention of avoidable death from aspiration pneumonia. So from preventing aspiration through reducing the harm from aspiration, and through early identification of aspiration pneumonia so that we can really action it. And I've just put in bold there things like postural support and upper body strength and cough a really important work. And if you've got somebody just sat in a chair, not moving, I'm preaching to the converted, but they're at very high risk of developing a chest infection. So really the take-home messages for you are: the person with a learning disability on your ward is at risk of dying. Learning disability should never be the cause of death or the reason not to resuscitate. If they're coming from a deprived area, they're at even more risk. And you could say the same about ethnicity. If they're a non-white ethnicity, they're even more at risk. And it's the question that, are we doing everything possible that we can to prevent people aspirating and developing chest infections? And just an ask that all the activities and reconditioning that you offer in whatever area you work, please make it available to people with a learning disability, and collect and publish and share and shout about any of the work you're doing, so that we can, you know, hopefully reduce lengths of stay, reduce readmission, and, you know, aiming to reduce mortality. So that's it. But I'm happy to take questions. There's just a few references on the back there, but there's the link to the British Thoracic Society clinical statement on aspiration pneumonia and community acquired pneumonia, because they realised there wasn't enough evidence to write a clinical guideline, which is quite significant. So we need evidence if anybody wants to do some research.
That was brilliant. Thank you for that. If you don't mind sharing the slides, I'll circulate them round. Then they've got the links. Really powerful stuff there, I guess, and, you know, food for thought. I'm just processing all that really in terms of the the thing that comes to my mind, and we'll open to questions in a minute if that's okay. That comes to my mind is that thing about seeing the person behind the diagnosis or the condition or the symptom or whatever it is that we, you know, there's the person behind that. What you know, in terms of their background, you know, what does normal look like for that person, and what's their normal life look like, you know, in terms of that, whether it could be deprivation or it could be a learning disability. And there's more to it, and, you know, possibly that we're not always able to, we're not able, but we're not always looking beyond the initial diagnosis and the treatment of a condition. And you know, we're focused on the treatment of a condition rather necessarily than the treatment of the person as a whole. Any questions for Anne to open it up? Janice?
It's not really a question, Fran. It's actually like, thank you for sharing the data. It's really powerful. But it's just like in West Essex and Hertfordshire, like what you have mentioned, we have a group of clinicians and operational leaders in terms of looking at how we can improve it across the board. And we have kind of a risk assessment tool that we are linking up with the frailty as well, acknowledging that frailty syndrome happens or starts with them quite early age. So we are looking at 45 years old. And how do we influence the integrated neighborhood team in kind of helping to timely identify those who are really at risk of developing early signs of frailty. But what we've also found out recently is, I know across the system, we have now been getting better in flagging patients who are attending the acute setting. But I think it's a focus. What we need is a focus on what are we going to do after we started flagging them, and is having like an aligned programs in terms of learning disability, specialist team, and the frailty. So like in Princess Alexandra, we are looking at the relaunch of our fundamentals of care in deconditioning, and getting much of involvement coming from the specialist team, so that it is something that has to be recognized that they do have these syndromes quite earlier on, and how do we do and manage them proactively and across the system, because health and care is very much connected with the subject matter. I mean, it's not just for frailty, but learning disability is a good example. What we found out is when patients moves to the acute hospital, we are very limited in accessing information that is relevant, because a lot of times they are not able to articulate it. And a lot of times as well, their relatives are quite, like, you know, the carer could be their mom who is like on their 80s or on their 90s. So it's very difficult to get information. But I think with the development of the interoperability in the area, so hopefully we would be able to get some oversight from an SCR, for example.
Thanks, Janice. It is about that, how sometimes that communication across the whole system, where information may be known, as Anne was saying, to a GP or even maybe a community nursing team, doesn't always get then transferred if the patient needs admitting.
Yeah.
So yeah, good point. Good point. Aside from question, to lead on from Janice's point, any other observations, comments? Anybody else kind of brain whirring after that? Josh, you put something in the chat. What was your thoughts?
Sorry, trying to look at the right camera. I've got screens all over the shop. Nice to see everyone, by the way. Very good presentation, and I think a lot of it comes down to also that early identification. I'm going to speak from a secondary care perspective, and at the first point of admission, we should be considering how patients, whether with a learning disability, frailty, or or other, in a sense, comorbidities, are what their discharge plan is straight away. It's a bit of work that I'm really trying to work on. We have a very good learning disability team at SNF who are really trying to push the agenda around the hospital passport, and really trying to understand that person's individual needs and requirements. And I think personally, if that carries through consistently throughout their journey, that's one element. Communication is a big thing, and as we know across our different trusts, we are in October will be go live for Epic, which we're all very, very excited about. So we're hoping that we can sort of build in a lot of this information that's required for these patients, throughout their journey, rather than being duplicated or missed. Some specific constraints I've seen over the years when I was clinical were, accessibility, bless to our speech and language therapy team to identify this early, or actually the confidence and competence of our nursing and other AHP colleagues to be able to support maybe some early swallow-based assessments or identification of dysphagia, so we can prevent the risk of aspiration pneumonia from occurring, full stop. Other elements also is where the funding and the equipment accessibility sits for suctioning in the community. Always a complete pain when trying to get a patient discharged, or who would be able to then facilitate that in the community. Is there work that needs to be done in a lot of our residential or nursing based settings as well around positioning? That there's so many different avenues to look at it, but that's my piece on that. But I think it all just come down to that early identification from that point of admission, and how we can have that consistent understanding of what this individual's needs are, like we would do for every single patient.
Thanks, Josh. Hannah, do you want to come back on?
Yeah, no, I was just going to say the early identification is so important. So like to plan for the discharge, but also at every ward round or, anything that we are doing regularly, is this person developing aspiration pneumonia? We know it's the biggest risk to their health. We know it's the thing they're most likely to die of during a hospital admission. So even considering it, and just as we'll do Waterlow scores, there was a time where we had way more pressure sores than we have now, but we really take that proactive approach to tissue viability now. And so it's, for the person with a learning disability, we need that proactive approach to prevention of aspiration pneumonia, I think, that will make that, if we know what worse looks like in this person, we'll know to look for it. But if people are totally oblivious to the fact that aspiration pneumonia is the biggest risk, then they won't look for it.
Yeah, it's the I was going to mention was, I think it is that awareness, be aware of the impact and the disproportionate impact of deconditioning or prolonged lengths of stay in hospital, or lack of mobility, lack of movement on certain groups. And I think we've probably done a lot over the years in terms of, for people living with dementia, there's greater levels of awareness and understanding. And I remember, I don't know, 10 years ago, that was in its infancy, I suppose, in terms of raising the awareness for teams on wards and in healthcare settings around the impact for people living with dementia, of the environment they experience. And it feels to me, I don't know whether it's the case or not, it feels to me that we're at that stage now for people with learning disabilities about, you know, a lot of this will be about awareness and understanding, as I said, about rather than just seeing a condition or a symptom or a bed space, whatever it might be. The question I was going to ask, Anne, I don't know if you have this data or it was in as part of the report. Do you know what some of the constraints are around discharge that leads to the extended length of stay? Is it the I shouldn't put words in your mouth. In my head, I'm thinking, is it that some of the often is a constraint around discharges around risk aversion. So we see something different in this person, and we're more overly concerned about this person, and from a safeguarding perspective, we then worry too much about what might happen, or is it access to further services in the community, or do you have any level of understanding what are the constraints?
So I couldn't say for all of those deaths, but certainly one of the themes that comes up quite repeatedly is where people move from care settings because their care needs have increased, and so they're not able to go back to the same care setting, say a supported living, because they need a greater level of care, such as nursing home care, and so there's that sort of delay. But with that, there's also the issue that there doesn't seem to be an anticipation of the advanced care, and the fact that if this person is becoming more frail, if this person is having increasing needs, that we can anticipate that this supported living environment isn't going to meet their needs till the end of their life. And so we need better advanced care planning, because what you sometimes see, particularly with people with a learning disability and autism, is that they don't respond well to the change, certainly when it's done, I use the word traumatically, with caution, but when it's been an unexpected change, people with autism work best when you can plan and sort of get them used to the idea, and they can have visits and you can build up to the move. And then whether it's sort of chicken or egg, people die very quickly in that new care setting. So that can often be the case. But we see a lot of sort of yo-yo admissions. So I think on the slide it said that like somebody had spent 64 days in hospital sort of during that previous year, which they'll be discharged. We've got a paramedic on our team who's got examples where people are sent home and back in the same day, and so it's an unsafe discharge, and whether that's assumptions that are made where people are going because it is a residential care setting, that they can cope with a greater level of care needs or whatever.
Yeah, get that. Yeah, Janice, do you want to come back in?
Yeah, it's just a reflection, and I think for us in Hertfordshire and West Essex particularly, we probably need to look at how we can empower our hospital at home or virtual hospital service to be confidently take over when they are acutely unwell, when they are able to be managed in the community, really. And maybe it's just a reflection while Anne was saying earlier is, do we have to increasing their confidence, meaning that we have accessible and responsive services to wrap around the hospital at home while providing an acute care in the community? Because I think a lot of the problems happen is, you would know what would be the journey of a patient with learning disability the moment you see them in A&E in the first 2 hours of arrival. You can predict. And for those who are in this call who have been working in ED, you know what I'm talking about. You can predict how the whole journey would look like, how long would the patient is likely to stay here, and even longer than what you predicted, because of the impact of the conditioning whilst they are in the acute hospital. And with all the goodwill, we wanted to minimize them, but still, we know that we could have prevented it if we have kept them at home in an environment that they can thrive better with all the care plans in place with less confusion. But always we were thinking about it, and thinking those patients also with early diagnosis of dementia, because how can we get them to be treated in their own homes? because there's a lot of evidence behind it to support that they thrive and they recover quicker when they are in a familiar environment.
Yeah, you just made me think there, Janice, actually, to work with something for in terms of engaging with the ambulance services or the ambulance service in the east of England. I'm just thinking about where that's sort of doing a lot of work with the ambulance service around care coordination, and as Janice was saying about how we can keep people at home more and bring care to the patient or the person, rather than often we all see somebody. We see this in the older population, the older frailer, that there's a bias or skewedness in terms of, or we need to say them to convey to ED, whether that's possibly something in the psyche and the heuristic of a paramedic on scene that in normal circumstances, whatever that means, they would have probably kept the person at home. But somebody with a learning disability, they may have a little bit of a unconscious bias to think that they need to be conveyed to hospital. Anne, do you want to come back?
Yeah, it was just a discussion that I'd had with Voyage Care about this, and like the potential for the wraparound service to give clinical care in a residential care setting. And they've gone away to look at their CQC registration status, because there's something about when people's care needs increase, whether they're compliant with their registration status. If they're then, so if you were in your own home and we had wraparound care, that, hospital at home or whatever, that would be fine. But when it's a registered home, whether that is allowed, and I don't know the answer to that, but if you are going to have those conversations with East of England ambulance service, it just might be worth exploring that, because I think that's sometimes the fear, isn't it, that when I was working in the mental health trust, we had a similar thing where people didn't reach the threshold of why they needed an admission to an acute trust, but their care needs had exceeded what could be delivered in a mental health trust. And so it's that issue where people then bounce backwards and forwards. It's not good for the patient, it's not good for either service. But it's just knowing what's like understanding what can be delivered in each care setting.
Yeah, well, I'm definitely going to take this away, and this is the conversation I will be having with the ambulance services across the. I mostly work with most of the ambulance services across the country, so definitely will be introducing this into our thing. Often these are related to frail older people that we think about, but actually this is a group that now you've triggered this in my thinking, and I hope that there's something that the rest of the group today and those who are listening on when you listen back to the recording, if you're not live with us today, if there's something you take away from this around, just introducing a level of awareness, even, just the information that Anne's shared with us should be a bit of a trigger to. This is a cohort of our population that sometimes we may not have that level of awareness that if we just trigger that a better understanding, I think, has been really helpful today. And so thank you very much for that. As I say, I'll share the presentation around with the recording afterwards.
I'll jump off because I've got to go to another meeting. But
no
thank you so much for having me.
Cheers.
Thanks so much, Anne.
Bye-bye.
In the last sort of quarter of an hour, if has anybody got anything they wanted to ask any questions of anybody, or anything they wanted to raise, not necessarily related to Anne's presentation, or just the work that you're involved in at the moment? Any questions you've got? If not, I can give you some time back and give yourself a chance to go and put the kettle on, or have a nice cup of tea, or whatever your beverage of choice is on a Wednesday afternoon at lunchtime. Obviously, the WhatsApp group's always open as well, so please keep communicating through there. We're having a few discussions in the background about what next, I think, for Recondition the Nation, and I think We've obviously Deb's here. We did the deconditioning games in the winter games. We've done the games across a couple of years ago. So where do we go next with these kind of conversations, and how do we maintain this work, which feels meaningful for the group? We've got an amazing network of people here, over 500 people linked to this group. We're regularly access the network in some kind of way, whether it's through these meetings or through WhatsApp or through the Futures platform. Yes, Fran, I'll pop the link in the chat so you can join. Yeah, so please keep connecting. Anybody wants to share their work, these monthly meetings are here for you. We have guest speakers. Deb found Anne for us, which was great. If you want to come and share some of your work, or if you know somebody who you want to promote and push forward into the limelight, then please do let me know. Ping me an email and we can get that lined up for a future session. So if there is nothing else today, thank you for those who've been able to join us today. I hope you found Anne's presentation useful, interesting, motivating, whatever words you want to bring in. I found it a little bit left field, but I thought I was really grateful when Deb brought it to us, because I think that's just a different angle to look at our work from, which sometimes helps to sort of stimulate our thinking a little bit. So thanks for your time. Have a good rest of the day, and we'll see you in a month's time.
Thank you.
Thank you very much.